I'm Paul Ginsberg, and I want to welcome you to this event sponsored by the USC-Brookings Schaeffer Initiative for Health Policy and co-sponsored by Brookings Center for Regulation and Markets. This is the third and last webinar of our series on regulating healthcare prices, created to honor the late Uwe Reinhardt. Our first panel focused on whether the U.S. healthcare prices are indeed higher than they should be. The second was on potential policy approaches that either have been or could be pursued in the United States, including caps on prices for out-of-network care, rate setting, and a public option. Today's panel focuses on lessons from the international experience in constraining prices through regulation. This panel would have been of particular interest to Uwe Reinhardt, who wrote extensively on how other countries have addressed these issues. As many of you know, Uwe was born and grew up in Germany, but emigrated at age 19, first to Canada and then to the United States. I had the privilege of traveling with Uwe twice to Germany, first to attend a small conference on healthcare costs convened by a German foundation, and later as part of a joint delegation from the Physician Payment Review Commission and the American Medical Association to meet with leaders of German physician associations and sickness funds, as well as government officials, to learn about physician payment in Germany. I was executive director of the commission at the time, and Uwe was a commissioner. We were at the commission together for 8 years. At the conference, a number of Germans who knew Uwe well joked to me about Uwe now speaking German with an American accent. The delegation to discuss physician payments was a follow-up to Congress's enactment of the reform that included the Medicare physician fee schedule. At the time, some older Germans were not that comfortable with their English skills, so Uwe did a lot of translating for our group. We have 4 excellent panelists today, and I'm pleased to introduce them. First to speak will be Reggie Williams, Vice President for International Health Policy and Practice Innovations at the Commonwealth Fund. He will help set the context for today's discussion. Miriam Laugesen, Associate Professor at the Mailman School of Public Health at Columbia University, will discuss the experience of 3 countries, France, Germany, and Japan, with regulation of prices. Adam Elshog, who was Professor of Health Policy at the University of Melbourne in Australia, and a visiting fellow at the USC-Brookings Schaeffer Initiative for Health Policy, will focus on the Australian experience. And finally, Chris Pope, Senior Fellow at the Manhattan Institute in New York City, will present some very interesting perspectives on the landscape of experience with price regulation abroad. After the 4 panelists speak, they will have an opportunity to comment or ask questions on other panelists' presentations. Then I will pose some questions of my own and turn to questions from the audience. Viewers with questions can use either Twitter, and that would be #healthcareprices, or send an email to events@brookings.edu, and those questions will be funneled to me. So we'll begin with Reggie now.
Hi, Paul. Thank you for the invitation. I am excited to speak with everyone here today. My goal is to level set on the different approaches to determining healthcare prices from around the world. But before I get started, I want to acknowledge Uwe Reinhardt. I met him about 20 years ago when I first came to Washington, D.C. and worked at the National Academy of Social Insurance. To say his wit and insights were profound is a major understatement. He is also a grantee of the Commonwealth Fund, and we cherish the insights he shared with us over the years. Now to today's presentation. I'm going to share a little bit about the Commonwealth Fund's international program, what we have learned about international spending and cost, share a high-level overview of price setting approaches, and considerations for going forward. First, on the Commonwealth Fund, we seek to promote a high-performing healthcare system for all with a focus on low-income people, the uninsured, and people of color. We have 5 major areas of focus, and I am the leader of our international program. The international program does a couple of different activities. The key thing that I want to focus on today are some of the research programs that we have led for over 20 years. We have an annual international survey of the general population, those over 65, and primary care physicians in 11 different countries. Through our Mirror, every 3 years, we conduct benchmarking of key indicators of access, administrative efficiency, equity, and healthcare outcomes. We also evaluate OECD data and distill implications for the United States, and maintain a detailed set of international healthcare system profiles to show how other systems in the world are structured. So as it relates to our work looking at healthcare spending, you see that the United States stands as a leader here in healthcare spending. When you compare us to other countries, the amount spent per GDP is obviously much higher. We look at this a level deeper when we conduct our Mirror, and we look at health system performance and spending at the same time. And unfortunately, the United States stands as an outlier when you look at both the higher spending and lower healthcare system performance. So on to spending and how it looks different across the various countries. This slide highlights hospital spending per discharge across a number of countries that we focus on in our analysis. And you see here again, the United States is a leader in healthcare spending. And you can see the dramatic differences across many of the high-income countries that we focus on as a part of our analysis. As far as where is money being spent, the money is being spent in hospital services. We see it as a predominant place where care is delivered and where expenditures are focused. This chart highlights differences between hospital, physicians and medical practices, and prescription drug spending. So when you look at that hospital spending, you can see how the United States fares across a wide variety of different services that are delivered. This slide highlights just a few. And you can see the relative magnitude of difference in the United States around hip replacements and angioplasty. But now I'd like to turn my attention to talking a little bit more about price setting and the different approaches we see. To start, there are many different approaches to defining the unit of activity on which prices are set. Common base payments are fee-for-service, diagnosed-related groups or DRGs, per diem, or capitation. Budget-based line item and global payments are typical in many low and middle income settings, but these are gradually being replaced by other methods. Payment methods directly linked to activities like fee-for-service, per diem, and DRGs require a well-defined planned episode of care and strong evidence that such care will achieve desired outcomes. We know that the fee-for-service methodology rewards activity. It tends to result in the over-provision of services because of the incentives for volume, regardless of patient need. Capitation is a population-based payment, whereby a fixed payment is made prospectively for a defined benefit package for a person for a certain period, regardless of the services provided. And a growing number of provider payment mechanisms are being deployed that explicitly seek to align payment incentives and healthcare system objectives. So we see the introduction of things like bundled episodes, global capitation, pay for performance, a wide variety of different settings. When you look at primary care across different countries, the most common means of purchasing primary healthcare services is through capitation and fee-for-service. And outpatient services are commonly purchased through fee-for-service. To counter the disadvantages of fee-for-service, such as the lack of incentives for quality and the incentive towards value, you often see it combined with other mechanisms to promote efficiency and cost control. For example, fee-for-service has been combined with pay-for-performance in France. In Korea, capitation has been combined with fee-for-services in Australia, France, and England. We'll be speaking a little bit more about those later. It's also interesting to see the mix in England where capitation is used for primary care, but fee-for-service is the focus for outpatient specialists. So you still get a mixing of these different types of bases for payment in different care settings. So turning to hospitals. Here you see the dominance of DRGs. The financial incentive or DRG payments have provided strong incentives for changing provider and hospital behavior. France has an interesting model of DRGs and bundled payments for public health services and utilizing pay performance, which is a particular note. Japan uses an interesting combination of diagnosis procedure combinations and weighted care per diems for non-acute services in both public and private hospitals, which can also be combined with fee-for-services and bundling together and creating one unit. We'll be speaking a little bit more about the Japanese experience later, but it is an interesting approach worth noting. So once you think about that, establishing that overall kind of base for payment, there are an administrative process or some sort of negotiation that takes place on those services that are being provided. These processes are grouped into three major methods: individual negotiations between providers and payers, negotiation between associations of providers and payers, and unilateral administrative cost setting. And that's where you see a lot of the variation across countries. In this slide, you'll notice that under individual negotiations, prices are agreed upon through negotiations between individual health insurers or self-paying patients and individual providers of healthcare services. Transaction prices are the result of many discrete negotiations, and they're often unknown to the final consumers and to the public. And the results may be treated as commercially sensitive. In the Netherlands, you see healthcare insurers negotiating contracts with individual hospitals for many services. Some insurers negotiate a lump sum budget, while others negotiate a price and/or volume for individual treatments. Furthermore, health insurers will then negotiate with multidisciplinary groups for single bundled payments to deliver care for, say, diabetes or COPD or asthma. In turn, care groups then negotiate with general practitioners for the delivery of primary care services. So this is a kind of a complex, multi-layered system that you see applied in the Netherlands. Under collective negotiation, you see an association of payers, health insurers, negotiate with the association of hospitals or doctors or other healthcare providers. The outcomes of these negotiations are typically displayed in a uniform fee schedule. We're going to speak a little bit more about Germany later, but it has a really kind of interesting approach where cost weights for federal-based prices are negotiated centrally. The DRG base rates for those states are negotiated between sickness funds and hospitals within a given range of set prices. And subsequently, at the local level, budget negotiations take place between individual hospitals and larger sickness funds. So again, you see this multi-layered approach taking place under collective negotiation. The third method of determining price is unilateral administrative price setting by a regulator. In the US, this is known as the Medicare approach that we see in fee-for-service. And it's also important to note Maryland's all-payer system, where both inpatient and outpatient services at hospitals are determined by a commission of stakeholders, but it has a global budget. So you can see how you can mix the different approaches with different bases of payment. Some of our other speakers are going to detail the Australian approach, and so I won't steal their thunder, but the Independent Hospital Pricing Authority demonstrates a clear approach to doing so. So ultimately, when I think about the lessons of other countries' systems and what they have for policymakers in the United States and others that are focused on this topic, I think there are really a set of objectives associated with price setting. You have accuracy, fairness, and the ability of the prices to ultimately support overall healthcare system goals. And there are ways to ensure price setting approaches meet those overall policy objectives. You have the ability to make adjustments as needed, controlling overall expenditure, managing balanced billing and patient protections, ensuring efficiency and quality in activities like bundle payments and quality incentives. And there's really a feedback loop that can constantly take place between these objectives and approaches. They're at times in constant tension, and policy solutions have an opportunity to balance them. And so I hope this gives you a little bit of an overview of how we can approach price setting in different countries. And please reach out to me if you have any questions about our work or how we pull together this information to distill insights for the United States. And now I'm going to pass the baton to Miriam to talk a little bit more about some countries.
Thanks. Thanks, Reggie. Thanks, Reggie. Okay, stop. And just a second. Thanks. That was a great setup for what I'm going to talk about now. And I'm delighted to be here. Thanks so much to Paul for the invitation and Brianna for technical assistance. So my talk is a brief overview of a book that we're working on. My colleagues at Columbia, Rutgers, and NYU, we are working on a comparative book, and I'd also like to acknowledge the help of research assistants and funding from the Tau Foundation. So I'm going to talk a little bit about the goals of the project, but primarily discuss sort of three main findings that we have that are relevant. So the start of this project really began from looking at the work by some colleagues, Ted Malmer, John Oberlander, and Joe White. And they had asked the question of whether fee-for-service is the fundamental cause of our malaise in the US. And I think the key point from that work was we need to think about the sort of multifactorial causes of higher health expenditure. So we developed a project which uses a sort of most similar design. So what we're doing in this project is trying to find and look at fee-for-service systems. We chose three, France, Germany, and Japan. These systems offer a lot of lessons for the US. We wanted to develop a really deep understanding of how these systems work, and in particular, illuminate the institutional structures that underlie the fee negotiations. Finally, I think it's really important when you're doing comparative work to be conscious of the differences and the applicability of foreign lessons. However, we also want to come up with proposals that could be acceptable and also counter this idea that the US is too different for cross-national lessons. So I think that's really important. We've basically been engaging in a study of the policy processes and the stakeholders in these countries. So we've been doing key informant interviews and document review in both the languages of the country and English. So let me just move to some of the key lessons. I think this heading would probably make Uwe proud. He appeared to be enthusiastic of puns and memorable titles. So one of the messages of our book is that fee-for-service is not necessarily the major problem that we have to address. What we need to address is a lack of standardization of prices. And so our book talks about the coexistence of fee-for-service and standardized prices. Other systems seem to make it work. So let's look at what realistic alternatives exist for making this arrangement work in the United States. Absolute values, absolute prices are a really important thing to keep in mind, and something that, we're aware of the higher prices in the US, but we lack the institutional mechanisms to really address those prices. The good thing about a generalized approach or generalized prescription that you could allow coexistence of fee-for-service and standardized prices is that they're sufficiently general that you can adapt them to a variety of different payers and systems. It's not a one-size-fits-all, depending on the level that you adopt it at. In any case, some of the most successful policies that we've had in the US have been fairly blunt. Now, I don't want to get into a debate about the readmission penalties, but I think that everybody agrees that for good or bad, they certainly had an impact. That's an example of a very straightforward policy that seemed to alter the incentives simply by changing the payment levels. I think simplicity is underrated in the debates around payment reform, and we should prioritize that and have greater transparency, and standardization would allow that. This would bring a lot of order to the chaos of the US healthcare system. But most importantly, and this is where we touch on US values, which are actually pretty consistent throughout the world. People everywhere want to be able to choose their doctor, as much as possible. And that's certainly something that fee-for-service does offer that choice, and I think that's important to consider as part of any sort of policy change. Our second lesson relates to stakeholder power, and any payment reform that doesn't address the fundamentals of stakeholder power is doomed to fail. In the United States, and I'll just speak about Medicare briefly, the rulemaking process is how we set prices. This puts the CMS and other and the agencies under the rubric of the Administrative Procedure Act. Instead of it being about sort of shared governance, what we have in the United States is a rulemaking process. And for some reason, payers don't really seem to participate in that process or exert a strong voice on those prices, even though they actually use those relative values. What we need is an approach that reinforces rather than works against what some people call civil society. And in some ways, the sort of paradigm of civil society is somewhat applicable, given that what we're talking about is people's health. We want to prioritize and make sure everyone has access to quality healthcare. And so the use of the term civil society seems quite appropriate. Fundamentally, though, payment is not always a civil process. It it puts one stakeholder against another often. And the answer to that is not accentuating that power, but to make sure that everyone has a strong basis, that everyone has an equal basis in that discussion. So I think the most important thing, and the thing that we've been really impressed by other systems, is how they get everybody moving in the same direction. And that seems to be a key thing that we have failed at in the United States. The third lesson is that we talk about how we may need to think differently about prices and coverage. There's always been a sort of a dichotomy in our healthcare policy environment around these two sort of separate issues, and yet other countries see them as unified. So our argument is that you need to have affordable coverage, you need to have good networks, wide networks, and until you do that, you can't put the coverage before the prices priority. You have to address both, and maybe what you need to do is address prices first as a way of lowering costs and increasing affordability in such a way that will improve coverage and affordability. I've been brief, and I look forward to answering questions, but pleasure to be here. And I'd like to introduce next Adam. So I'll just stop my screen share.
Miriam, thank you very much. And I'd like to say thank you to the Brookings Institution for inviting me to participate today. I too will just share. Excuse me one moment. Okay, here we go. So look, I'm in my 8 minutes, I'm going to do what I call a shallow dive into Australia, and really just provide, I think, two examples. One where we seem to be struggling a little bit to get our prices under control, and another example where I think we're doing a very, very good job. And before I get to that, I know Reggie gave us a quick overview of some of the Commonwealth Fund data, but just to place Australia within context in terms of its performance, the Mirror data does show Australia performing quite well against its peer countries. I will point you down the Australian column to equity, which it scores a little poorly on, and I'll be picking up that point in some slides down the road. And because we're talking about mortality amenable to healthcare, I think it's also noting that Australia's performing both within the country over time, but also between peer countries quite well on mortality amenable to healthcare. So the takeaway point from these two brief slides is that I think it can be considered a high-performing healthcare system by any standard. This paper from Papanikolaou, which is also drawing on OECD data, much like the Mirror work, gives us a little bit more information about some of the similarities and differences between the US and Australia. So at the top there, we seem to be achieving these outcomes with around about the same, slightly more physicians per capita, more nurses per capita. If you drop down to that middle green circle, we have more hospital beds, more long-term care beds. And most importantly, down the bottom there, which is the healthcare spending, we're managing to achieve all of this at just over half of what the US is spending in healthcare. So these data are a little old. It's suggesting 9.6% of GDP. We've recently ticked over to 10.3% of GDP. But the point is that it's still quite a long cry off the US healthcare spend. Okay, so some high-level points. So Australia has a universal healthcare system. So all of our 26 million population are covered, but we are not a single payer, as some other examples have been spoken about already today. So there are actually three main areas of contribution. The Commonwealth government, or the federal government, as you would recognise it. There is quite a large private contribution. That's both through out-of-pocket costs, but also there is a supplemental private health insurance option in Australia. And then the states contribute quite a lot to healthcare. I'm going to focus on just a couple of these inputs, and you can see from the chart there that there's actually quite a lot of complexity into the funding flows. I'm going to talk a little bit about the ambulatory and outpatient care setting. This is effectively our Medicare fee-for-service system, and with a degree of out-of-pocket cost sharing as well. The large bulk of our healthcare funding actually goes to our public hospital system. So these are state-administered public hospitals. They're free at the point of care, so there's zero out-of-pocket costs or co-pays associated with care. They're funded through a combination of block and DRG activity-based funding to a nationally efficient price and a nationally efficient cost. And I think that's something that the US could take away some lessons from. It's also worth noting, although I won't speak about it in my 8 minutes, although we may come back to it in the presentation, is that we also have quite a degree of private hospital activity, of course, through our private insurance option as well. So first of all, to our ambulatory and outpatient care. So our Medicare benefit schedule has over 5,500 items on it. The way doctors are, and these are doctors, primary care physicians or specialists working in the outpatient setting, clinics and the like. The providers there can either bulk bill, which means that they accept the MBS fee as full payment for their service, or they can charge a co-payment in addition to that. There is safety nets in place, which interestingly has actually drawn out some perversities and some gaming of the payment system, which we can talk about later, but there is a safety net there. If we had time, I'd take a quiz on what people think are the bulk billing rates for primary care physicians and also specialists, but we don't have time, so I'm going to jump to the answer. You can see the top red line there. This is our non-referrals. This is our primary care doctors, or our GPs, as we call them, general practitioners. Currently, the proportion or percentage of consultations that are bulk billed are sitting at around 86%. So 86% of those consultations, the primary care physician is accepting the Medicare benefit schedule fee and not charging a co-payment. For other specialists, it's sitting at around 43% at the moment, which you wouldn't be surprised at. And if we break down further between specialties, you can see that for some, they're very low. So as low as sort of 15% are bulk billing, others are much higher at around 60%. Now, in this graph, we aren't showing ophthalmologists or dermatologists, and they tend to be much lower bulk billers as well. But you can see that this is perhaps not so surprising. And this is where our equity issue starts to come into play. So there are access barriers here around cost. And if we jump to some work, all of this, by the way, is work that was published by Gary Freed, who is actually an American who had done some work in Australia. So if you think about what sorts of costs we're talking about, I've drawn out just the mean columns, but feel free to peruse the other ones. So for the cardiology at the top there, the overall fee that's being charged for an initial consultation in the outpatient setting is 202 Australian dollars, or as of yesterday's exchange rate, that's 144 US dollars. And there is an out-of-pocket charge of 52 US dollars on average for cardiology, and that's the initial outpatient setting. And if you cast your eye down there, you can see how that varies. So this is where Australia is starting to lose out on equity of access, hence our lower score on the mirror findings there. And it's a problem. So Australia is now struggling with the idea of runaway out-of-pocket costs as being quite a problem in the ambulatory and outpatient setting. Turning our attention now to the good news story, and that is our public hospital system. So these are our large tertiary care facilities, teaching hospitals. They carry most bed days within the country. Interestingly, our private hospitals are performing just over 50% of the elective procedures, but actually most of the sick patients are spending most of the time in public hospitals. So as I mentioned earlier, they're funded through a combination of block grants and DRG activity-based funding to a nationally efficient price. The group that does this is the group called the Independent Hospital Pricing Authority that Reggie intimated earlier. And their website is quite worth a look. They do a lot of things. One of the things that they do is they set the nationally efficient price, and it's set annually. It has two key purposes. One is to determine the amount of Commonwealth government funding for public hospital services. So the Commonwealth government wants predictability about their allocations going forward, so the nationally efficient price does that. As, or perhaps more importantly, it provides a price signal or a benchmark about the efficient cost of providing public hospital services. And you'll notice the word has changed to cost there. So all hospitals here are required to contribute to a minimum national data set. which is the cost inputs for providing care for certain services. And it's those inputs that help the IPA to define what the nationally efficient price is for the country. So it's based on an average cost of an admitted acute episode of care. Each episode is allocated a national weighted activity unit, or an NWAL as we call them. And that's a measure of hospital activity expressed as a common unit against which the NEP is paid. So it's really a point of relativity for the pricing of hospital services, weighted by complexity, and there are other adjustments to them as well. So an average hospital service is worth 1 NWAL. If it's more intensive or expensive, it's a multiple NWAL, or if it's less expensive or simpler, then it's a fraction of an NWAL. So the national efficient price for 2021 is Australian $5,320, or USD 3,808 per NWAL. Just to give you an indication of what that looks like through a set of examples of services. So regular tonsillectomy is equivalent to 0.7398 NWALs, which equates to almost 4,000 Australian dollars, or almost 3,000 USD. So yesterday I looked up the HCCI and the Florida Health Provider Finder website, and they said that the US national average price is almost $5,000 compared to Australia's US 2,818. Coronary bypass with minor complexity. I couldn't actually find this in the HCCI or the Florida Health Finder website, so I searched a number of sources and saw a range of between 44 and 248. But given this is for minor complexity, again, even if you were to look at the lower bound of that, Australia is coming in quite a long way underneath that. And for hip replacement, you can also see. And the note that I'll make there is that the US national average here actually is a bundled price, and it includes 10 rehabilitation sessions, and the Australian price does not include that, but still, it's still a multiple off that fee. The most important takeaway from the national efficient price, I think from a US perspective, is the rate of growth. So since the introduction of our nationally efficient price in 2012-13, the NWAL rate of growth has reduced to a sustained growth rate of 1.9% annually in that time. So it's been enormously successful, and it's really down to that benchmarking exercise that I spoke about, where states are incentivized to ensure that hospitals that are performing above the nationally efficient price can manage to bring their cost structures down to meet that, and so on. And we haven't spoken at all about pharmaceuticals today, as per the previous sessions, but I'd be happy to do so in the discussion. It's another area where Australia is performing very well in controlling its prices. And I'd also, if time allows, if people are interested, I'd like to touch on our private and hospital system and our private health insurance. That is an area, again, where we're struggling to keep our prices under control. So with that, I will hand over to our last speaker, Crispo. Thank you all.
Thank you, everybody, for joining us today. Thank you, Brookings, for inviting us all to speak, and thank you, everyone who's tuned in. So I'm going to do basically some comments and thoughts on really what characterizes the nature of approaches between countries, and really to try and bring out some of the commonalities. I think there's generally a desire to see American exceptionalism everywhere in healthcare, which I think at some level is sort of motivated by the desire that there's an easy fix out there, that if only we could copy, like there's one kind of mechanism that another country's offering, then we could quickly solve it and move ahead. But I think or at least what I've noticed from studying a whole variety of different payment systems across the world, is that if you don't see a trade-off in one place, the exact same trade-off tends to arise somewhere else. And every single country's healthcare system is perpetually dealing with the trade-off between quality of care, access to care, the breadth of people who can afford care, and then the cost of care, and who bears the cost, who is able to have access, and how quality varies between different patients and the care that they're able to access. And there's really no getting away from this. No country really ever gets away from this. Regulated prices, market prices, and attempts to sort of constrain or engineer market prices or nudge market prices are all ultimately constrained by this sort of same fundamental underlying dynamic. Regulated prices are really constrained by the same supply and demand concerns and considerations that market prices are. And when we think about the regulatory process in various countries that is trying to constrain prices, in its attempt to reduce costs, it has quality and access concerns that, again, are constrained by some of the same drivers that we think of as driving market prices. The regulatory process is not in any way exogenous. It's very much part of the healthcare system. And to sort of think about a regulatory process might come in to fix prices or manipulate prices, it's quite likely that when you have a regulatory process or a regulatory intervention, the regulation will end up replicating many of the same features that have emerged with what isn't a regulatory tabula rasa, but ultimately a whole host of accumulated regulations. Certainly in the United States, we've seen 70 years of regulations trying to do indirectly what other countries have done more directly. And so I think that if there's a theme of my quick overview, it would be that every road leads to Rome, in a sense. Things that might look like American exceptionalism are actually pretty similar to things that other countries are doing. I think one of the key driving dynamics about healthcare systems, and we talk about private systems and public systems, but pretty much most healthcare systems in the developed world are mixed systems. This is certainly true of the United States, where about 50% of our spending is public and 50% is private. But it's true certainly in Australia, we just heard. It's true in Britain to some extent. It's certainly true in France, Germany, Holland. Every country is essentially trying to balance public and private resources, and trying to set prices with an eye to basically maximizing the returns to both. There is everywhere, I think, a desire to have private revenues relieve strain on the public system. If people can pay for their own care, that means that public resources can be used elsewhere. But then that kind of runs into the opposite concern, that if you have a very high private willingness to pay, that's quite likely to drive up costs, not just physician fees, not just payments for kind of discrete services that are inelastic in supply, but also the intensity of care. If you think that there's a willingness to pay on the private side of more affluent consumers and insurers that have a high willingness to pay to attract them, that will tend to drive up costs. It will encourage hospitals to increase capacity. It will encourage hospitals to upgrade their capital services, and that can tend to create a cost pressure that feeds down to the public system as well. That's certainly a feature that we noticed in the United States, but I think it's the dynamic that's present everywhere. The flip side of that, I think, is a similar dynamic that we see in the United States, which is a deliberate desire to harness price discrimination between payers. Now, in the United States, we certainly think of we've become accustomed to private insurers paying more essentially for the same hospital services than Medicare or certainly Medicaid would, and a similar dynamic happens in other countries as well. We see certainly in Germany, there is a private and public fee schedule, but the private fee schedule is higher, and that's quite characteristic. The desire to spread overhead costs and have private payers pick up a disproportionate share of overhead costs, I think is pretty common around the world. And again, a flip side, the danger of a public-private interaction that constantly arises is really almost the moral hazard, or sort of like this danger of cost shifting, danger that providers or entities or even payers in some circumstances will seek to privatize profits and socialize losses. That's always a big concern with any kind of mixed public-private payment system, and any kind of healthcare payment arrangement around the world is essentially trying to deal with that dynamic and avoid what can obviously be quite a dysfunctional arrangement. So when we think about rate setting arrangements around the world, it's easy to sort of think about the dichotomy of market pricing and sort of administered pricing. But in a few cases, that's actually the case. I mean, if you think about every healthcare system, or certainly most healthcare systems, as mixed economies, Certainly in the United States, we see fixed pricing in Medicare and Medicaid alongside market pricing. That's true of several other countries as well, have similar arrangements. Fixed pricing with balance billing is an arrangement that we certainly see in France. The public hospitals and there will be a public fee schedule as well for physicians, but they're allowed to balance bill with private insurance allowed to reimburse for fees that are balance billed above the fixed reimbursement from the public fee schedule. And so again, there you have a complex interaction between a public fee schedule and a more unregulated private reimbursement arrangement. We have market pricing up to fixed ceilings. To some extent, that happens obviously in various countries. Holland, in some cases, that is the arrangement. In the United States, we see market prices with strings of various sorts. If you think about how there we have network adequacy rules that are designed almost in some ways to influence the pricing power of hospitals. If you think about the way we have like charity care requirements for the tax exemption of hospitals, that again influences market pricing. It influences barriers to entry into the marketplace. And so there are a lot of indirect tools that countries use to influence market prices. What on the surface might appear to be a market price might be the sort of the end result of an indirect regulatory approach. What we see also is quite commonly is what appears to be a market price really being a fixed price that's generated through indirect regulation. Now, there are cases in which one thinks maybe of Canada, where like the private healthcare or private insurance isn't completely in every province made illegal, but through systems of regulation, it's very much constrained out of existence. And that's quite typical of healthcare systems as well. And then we would have, you can sort of think about different types of fixed pricing arrangements. I've already spoken about Germany, where there are multiple tiers of fixed prices for different payers. In a sense, one could think about France similarly, and then just the ideal of sort of all payer fixed prices, where you might have across the board prices that are the same regardless of payer. So there's an enormous diversity of payment arrangements in terms of the underlying politics and the underlying mechanisms. Even it's something that might overtly seem to be just a fixed fee is actually not quite so simple under the hood. Now, physician payment arrangements, to sort of enumerate the types of arrangements we talked about, or Miriam earlier talked about fee-for-service and capitation, and Reggie touched about on this as well. And when you sort of think about the diversity of these kind of payment arrangements, the diversity that exists within other countries is very similar to the diversity that exists within the United States. We have fee-for-service payers. We have payers that manage care providers that have salaried physicians, and that's quite common. Again, a big battleground that I think that we see politically in other countries is the issue of dual practice rights. And these are often tied in the payment arrangements. So if you think about the way that France sets its public payment schedule for physician fees, that's very much tied to sort of trying to optimize the incentive for physicians to participate in the public payments, the public healthcare system. And dual payment rights are calibrated and restricted to an extent that they will encourage physicians to cater to the public system at lower costs than they might otherwise do so. And so the interaction of these regulations with payment rates is often an important battleground and a key consideration. Similarly, hospital admitting privileges and gatekeeping rights are often tied in the physician reimbursement in quite complex ways. And so you look at the fees, you might not necessarily be getting the real picture. Volume incentives are often also tied into like physician contracts. And you can look at countries that are doing this, but to some extent we have utilization management under managed care that does much the same thing. And so whatever controversy politically you might think that there might be with increasing cost controls within managed care, one might likely run into a similar kind of controversy if I was effectively trying to do the same thing through a regulatory approach. Now, I think it's also sort of worth bearing in mind, obviously, quite commonly people in a cross-national healthcare talk will compare costs, and obviously the United States costs are off the charts. But it's also worth sort of going back to compare like with like. And if you sort of, the most important thing here is that healthcare is fundamentally very intensive in high-skilled labor. And when you compare like wage rates for very similar, for equivalent medical providers in the United States and in Canada, the wage rates aren't actually that different. There is a disparity. The disparity tends to be that the United States has more expensive physicians, more expensive specialists, and that will tend to drive up the aggregate costs. There's more gatekeeping, and so if you bundle all physician costs together and get an aggregate, you have a higher intensity of mix in the United States than you might in Canada. But comparing like with like, it is ultimately the same labor market with NAFTA. And so there is not the huge price disparity that really is the case if you were to compare North American labor costs with labor costs for physicians in France, where we're talking about an order of magnitude lower. A similar situation is the case with hospital payment arrangements. If we think about how different types of rules that exist, again, it's very hard to sort of pinpoint one variable, one lever that you can tweak. In all kinds of different countries, you find a web of different instruments that are used in sort of interacting ways to constrain costs, to create leverage against providers, to sort of almost increase the ability of regulators to drive down the price by kind of restricting volumes. Again, thinking from a supply and demand perspective, if a regulator is trying to drive down the price, it almost always has to start by driving down the quantity, which is, certainly if one imagined doing that in the United States, quite a political challenge, to say the least. That's why I think when sort of thinking about the potential of a regulatory approach, it's probably most instructive to look within the United States what regulatory approaches have been able to do at the state level. And the best example of this, certainly from a payment regulation point of view, is the case of Maryland. If you were to look at, Maryland's hospital payment regulation system has existed since the 1970s. And if you were to look at the cost trajectory of hospital care, hospital spending per capita in Maryland, relative to neighboring states, relative to the United States as a whole, it's certainly not the case that Maryland has had a very high level, from a high level, has had a significantly lower cost trajectory than the rest of the United States. If anything, it's been slightly higher. If you're thinking about states that have had a good cost control experience, you might think of other states in the Mid-Atlantic region. Maryland wouldn't really be the one that you would pick out as a good cost controlling type system. And if you think about it, this has something to do with why is Maryland the only hospital payment regulation system that survived? Massachusetts, New Jersey, New York, a whole host of blue states had hospital all-payer rate setting arrangements back in the 80s and 90s. And Maryland is basically the one that survived. And the reason that it survived is that it was basically the softest on costs. And really, to a large extent, it's probably helped drive up hospital spending because it entitles the state's hospitals to a big revenue boost from the federal government for Medicare patients. So why are hospital costs so phenomenally high in the United States compared to other countries? I think the fundamental dynamic is probably the one that we sort of think about as the medical arms race. Now, I cite the cost of MRI scans in the United States just because the numbers line up in a pretty kind of intuitive way. So you probably think about this as a stylized fact more than anything else. But I think it is characteristic of really the dynamic that's out there. We have more MRI machines, 3 times more than France, but about the same amount of MRI scans. So they're getting more out of the same amount of equipment. And that means that they can essentially have an average price that is lower and an average cost that's lower, and the price is lower. We don't really have a mechanism to eliminate this kind of excess capacity or to discourage the development of this capacity. In effect, we actually sort of have incentives that are aligned in the opposite direction. Most people get their healthcare from their employers. Your employer has staff that covers, like your employer has maybe 100 staff, a couple of hundred staff in all different neighborhoods. And so they need to have all the local hospitals in their network. That means that all hospitals are covered and most patients are well insured. And so patients are shopping on quality and convenience, not price. Price is not what gets hospitals nice reimbursements. And so the incentive is for them to always upgrade their facilities and upgrade their equipment and to try and be the best kind of cutting edge facility. That's a dynamic that drives up costs kind of constantly. And so it's a little deeper. The prices tend to be an outcome. It's more a dysfunction that we have that's unique, I would say, to the payer being dominated by group payment for care that is ultimately pretty price insensitive. As a sort of final part of the landscape, I just kind of wanted to sort of quickly touch on the issue of drugs, is when you sort of think about the what are called regulated prices in other countries. There's a lot of rhetoric about value and assessing like optimal value. But when it comes down to it, what are the actual levers that other countries have? Overwhelmingly, it's just to leave a drug off a formulary. It's to not refuse to cover a drug that's a high cost drug. Other countries, maybe they have reference pricing. They say we'll cover drugs up to this price, and then people are on their own for marginal costs above that, incremental costs above that for drugs in a class that cost an incrementally large amount. And that obviously creates leverage. Now, we could do this if we allowed drug plans to be more aggressive with formularies. We could allow drug plans to do reference pricing, certainly to an extent that they're not permitted to do under Part D. But it's essentially a lot of tools the private insurers already have. Now, we're deliberately choosing to not allow them to employ these cost control tools, which means that on some level, the United States has more generous access to drugs than most other countries, more generous coverage of drugs. If you think about the share of household consumption that's out of pocket on drugs, the United States is way down there because our drug benefits are structured to be very generous. The flip side of this, as everyone knows, is the cost of prescription drugs, or at least the cost of plans for prescription drugs, aggregate spending on prescription drugs, and prices for prescription drugs, and also physician-administered drugs in the United States are much higher than they are in other countries. But at the end of the day, it kind of comes back to the same fundamental trade-off that underlies everything between quality, access, and cost.
Thank you very much. All 4 of you had a lot of interesting things to say. Let me ask if any of you would like to offer comments, elaborations, or anything else on what your panelists have said.
Paul, if I may, given there's a pause, I guess just to start off on Chris's last point about the drug coverage. When we were planning this session, there was some discussion between the group around whether we ought to jump into myth busting in some areas. The pharmaceutical prescription medicine area is one that is really rife with myths about how other countries do it, and it's quite a shame because, in fact, many of the other countries that do have quite novel purchasing policies are really relying more on market mechanisms. So there's a real irony there that it's sort of basic market purchasing mechanisms that are allowing them to achieve the lower prices. So the idea that they're sort of just missing out on drugs. So for Australia, there's simply no evidence that Australia's missing out on any drugs that are of value, and that's the point. And within a class, you can say, well, you need access to 6 or 7 drugs. Well, why? If they're all Me Too drugs that are doing the same thing, why do you need access to 6 or 7 drugs when 2 or 3 might be all you need? And in fact, what tends to happen in countries like Australia through our reference pricing and our cost minimisation analyses is that we actually find that drug companies are coming in to actively compete with one another to reduce the prices for us. So we are not demanding lower prices. They're coming in because they want market, and they're coming in and undercutting their competitor to lower the prices. So it's actually quite a functioning element there. And I pointed to a paper that we wrote in Health Affairs a few years ago. You can see some of the charts that we provide. There's clear evidence that any time a drug is rejected, it's rejected on a value basis. And what happens is what happens in a market. The manufacturer tends to come back with a new price, and if it's still not cost effective, they get rejected again. And then guess what? They come back with a lower price again until they reach a willingness to pay threshold, and then it's added to the formulary. So it's actually quite a functioning system, and it's a myth, I think, that has crept into the United States that somehow countries are losing access. And the ultimate dividend there is it's playing out in our health outcomes. You've seen the data.
Actually, yeah. Let me turn to Miriam, and because I was hoping that we could focus on services, and I don't want to go too far into prescription drugs. Miriam, was your comment about something other than prescription drugs?
Yeah, no, it wasn't. Quick question, comment for Chris. I really enjoyed hearing about your comparison of MRIs and the quantity, and I think the point you were making was related to productivity. And I think that's something that, maybe there's more to be squeezed out of our system. If we can focus more on productivity, that might be where we find savings. That's all.
Yes. Thanks. Actually, I had a perspective on from Chris's finding, because I was part of a McKinsey Global Institute study a number of years back that tried to understand the differences in spending between OECD countries and the United States. And one thing they really focused on was the outpatient sector. And the perspective I got there, which I think comes through very well in Chris's slide, is that if you happen to set the price very high, as the United States has done for MRIs, what happens is a lot more capacity comes in. A lot of people do it inefficiently because there's no price discipline. In fact, even in the Medicare program, which tries to have an administered price system, they look around at the capacity utilization and they allow a high price in Medicare, not as high as private insurers. So in a sense, it's something where it goes, once your prices are high, you invite a lot of entry, kind of like monopolistic competition. You invite entry, the productivity goes down because people are doing it not at scale, and it perpetuates the high prices.
I think something that's interesting with the when you think about productivity in a sense is that that's, I think, quite often linked with the concern about rationing at some level. So if you think about the most efficient hospital is one, from a cost perspective, is the one where there's a shortage of beds, because there are no missed appointments. Like, say you got 100%, 110% of capacity, like you can have people in beds like end to end, and you can schedule very tightly, and that's very, very efficient from a spreading overheads perspective. When you think about hospital care, like so much of hospital care is certainly in the short run overhead costs. Even the labor cost in the short run is overhead costs. And so when we think about the United States, you look like the average hospital capacity in the United States is like in the low 70%, 73, 75%. In Europe, it's like maybe 80, 85. But in rural areas in the United States, we see that it can be in the 30s and quite often lower. And so this question of like, is there efficiency to be squeezed out of the system? system by getting the capacity up or kind of shrinking down, like what we're willing to tolerate in terms of access to facilities. That's a really challenging one politically. If you think about like rural hospitals, rural access to care, there's an enormous amount of inefficiency that comes from that. But you very quickly run into a lot of political constraints, and the political constraints that you thought were driving up, or you thought was a market system driving up costs, it turned out there was a lot of politics behind those market prices. And you run into the same politics if you try and set administered prices that are any lower. So I think that is my greatest concern with the notion that the administered prices or kind of any kind of regulated prices would make much difference to things, other than setting a payment floor. Every hospital is happy with a floor rather than a ceiling, obviously.
Thanks.
I wanted to build upon that a little bit and really talk about kind of the data infrastructure that underlies this and the transparency associated with that. And Miriam, I would love to kind of hear from your analysis and work with stakeholder engagement, how you actually use the data and information, those inputs about cost and output, to balance some of those trade-offs that Chris is talking about.
I think the payers in other countries traditionally have somewhat lagged the United States in terms of availability of data traditionally. I think they're catching up. But I think the data is used for very different purposes. And I think that the challenge that we have in this country is we have a lot of access to data, but it's so bifurcated between different payers and different payment systems, and there's no sort of standardization. So I think other countries are developing. Germany's developing its capacity in terms of health outcomes and looking at quality and issues like that. I think there's definitely a lot of movement in that area.
Thanks. Let me turn to a question I prepared, which is, considering the various high-income countries mentioned in these discussions, I presume that some might be better candidates than others for the United States to learn from, given the differences in financing delivery systems. In other words, particular price restraint policies in some countries have more potential to fit into the United States system. What characteristics make a country more suitable for us to learn from?
Without directly answering the question, I think the most helpful thing to think about which other countries to learn from is which other countries started out with similar sets of problems and faced similar sets of problems in the past. Rather, I think that there's this game in health policy that you kind of pick your utopian healthcare system and say, I would like to leap over and have this kind of arrangement. But looking at a country that has faced a similar set of challenges in the past and attempted to address them and done so successfully, hopefully, that's probably the best way to go. I think in terms of our problems, if you think, I kind of agree with Miriam's point that what she called lack of standardization, what I think often gets referred to as fragmentation between payers. And that's a problem that the Netherlands had really for many years. And then about 20 years ago, for a number of years, they worked on really consolidating their payers, aligning them with individuals, moving away from an employer-to-employer fragmented system. And then you can have a more systematic concern about price determination and the factors that are determining prices. Whereas I think a great vulnerability that we have in the United States, because we don't just have different payers, we have entirely different types of payers. Any conversation can quickly get nipped in the bud, quite often quite far down the process, by saying, yeah, but what about this strange circumstance where a proposed reform is going to be completely inappropriate? And obviously interest group's pretty good at finding those kind of excuses to torpedo cost controls.
Thank you. Any other thoughts?
Paul, I would just add that I think There's been myriad of reforms over the last decade through a number of countries. If you think about Germany, who we've spoken about, and the Netherlands, one of the things I think that is a great takeaway is that these countries who have been so willing to go down the path of reform, and I think from that there could be learnings both of things that have worked well and things that have not worked so well, and being open to that and having the data to demonstrate those strengths and weaknesses is important. I think from the Australian example that I gave around the IPA and the simple, I think, step of collecting input data. So, cost input data from across the country, from all, public hospitals, at least allows you to get a handle on what are the input costs to provide these services from which you can start to benchmark pricing. That alone, I think, is quite a novel and very important insight that I think most countries would gain from.
Oh, thanks. Question came in on Twitter, and I'll read it. We can't learn from other countries until we get past American exceptionalism and the line that we have the best results in the world. The question is, are we approaching that acceptance?
I would say, from the work and analysis that we've been doing at the Commonwealth Fund, that there is an increased desire to look at international comparisons. I think the recent experience we've had around COVID-19 and looking at how different countries have approached managing the pandemic has really opened up many people's eyes to looking to other countries for insights. And we've seen a dramatic uptick in policymakers and the media and other professionals kind of seeking those insights.
Thanks. Got a question. Actually, in general, to what extent have other countries become enthusiastic pursuers of alternative payment models like the United States seems to at the moment? Or I remember Miriam started out as, if you like your fee for service, you can keep it. Has the rest of the world, for the most part, said, we can manage fee for service?
I think there's certainly been a lot of controversy. There would be a lot of controversy around the statement that fee for service is, great, but it's sort of what a lot of countries use. I know from New Zealand, where I'm from, that it was also, it's been much maligned, and I think that has driven interest in other funding arrangements. I think the question is how changeable a system is, and I think like France, Germany, Japan, they're less likely to fundamentally reform all of their payment structures.
Go ahead, Adam.
Well, and Australia is similar. I mean, to Chris's point that he made, very good point about the blended payment models. I mean, Australia is actually looking to the US in some ways. As I showed you in my chart, there is quite siloed funding structures in Australia between Commonwealth and state governments, which, really doesn't lend very well to integrated care across the system. So we're really trying to think more towards blended models. I don't think we'll ever do away with fee for service, but it's about the complementarities that we can meet.
Yeah, and when you look at the high income countries, I think there is a great amount of interest in looking at bundled payments, pay performance, the use of quality incentives, and other approaches that are very common in America. And one of the things that we have seen, particularly with our research partners that come to the United States from other countries, is a real desire to understand, how do we introduce those types of innovations? They look at things like Medicare Innovation Center as a potential model for ways that they can introduce these types of innovations around bundled payment, pay for performance, and others in their countries.
Yeah. One thing I'm struck by is that, some time ago, how many countries adopted DRGs for their hospital payments. And it wasn't just because of the technical, because going to DRGs for them must have meant either getting away from cost reimbursements or getting away from, much more a fee for service approach. So was that kind of, I guess, do you see anything like that, as Reggie was mentioning, happening today, as far as great interest in what we're doing?
Yes, in Australia. So bundles indeed, even sort of mixed capitation, blended capitation, fee-for-service models. It's all. No one quite knows where to introduce these innovations and at what scale, but they're certainly happening, usually at a state level. So quite similar to the US as well. There have been some innovative hotspots at the state level. So it's moving in that direction.
Okay. Question for Adam. What's your assessment of how successful the structure of public and private coverage has been in Australia and the ongoing challenges?
Yeah, so it's really reaching a bit of a point now where the country's starting to reassess that blended model. So for history, over 20 years ago, a right-leaning government introduced some policies that really incentivise people to take out private health insurance who would not have otherwise. There were tax penalties and the like, and it took the coverage from about 33% to almost 50% of the population. But as Chris pointed out, sometimes when you have these mixed systems, what that does is it drives the higher prices in the private system, and that has occurred. There have been 6% year on year private health insurance premium rises. So there is talk in Australia now of a potential death spiral of private insurance because younger people are dropping out. And there's questions around the role of a Commonwealth or a federal government that subsidises private health insurance to quite a large figure now, almost $8 billion per year to subsidise people taking out private insurance. So there are questions around whether that money would be just better off going back into a public system to cover everybody, particularly with these inequities that are starting to appear in access to services across the system. So I watch this space. I'm actually writing a paper with Bruce Landon on this very issue around these tensions that are occurring. And I think if the government were to remove some of those incentive payments and subsidy payments, I almost think private health insurance might almost fall over or get to a point where it's no longer viable. Yeah.
Oh, thanks. Chris mentioned in his remarks that many countries allow their salaried physicians to devote a portion of their time to private practice, where I presume wealthier patients pay high fee-for-service prices. What are the consequences of this practice, which we see in a number of countries, for overall spending and access to care?
I can speak about that. I think this is it's sort of a myth, I think, that if you have that sort of private sector, it's going to totally undercut the public sector. I think that in some cases, that it acts as a sort of a bit of a valve for pressure from very wealthy people. The question is, would it work in the US? We have a lot of very wealthy people, and it's a much more unequal society. So perhaps, that sort of arrangement would be more challenging in the US than in, say, Germany or Australia, where they do, or France, where they allow some of that sort of build-up of demand for, private care.
I guess. Oh, go ahead, Chris.
I see that almost as like the heart of the art of health policy is like trying to gets this ideal where private spending supplements public spending, or public spending supplements private spending, rather than supplanting it. And that's there's no simple recipe, because all the sources of all the potential pitfalls there are pretty numerous. Everyone wants to game the system, and the more complex it gets, the more difficult that gets to prevent. But I think that really is the game. Like, if done well, you are bringing more private resources into the healthcare industry that add on to the public resources that would otherwise be available. If not done well, then you can end up with a system where, like, wealthy people get all the care and public system gets higher costs, and that's definitely not what you want to set up. And you can easily fall in that kind of system just because of the way the interest group politics might push you.
Yeah.
And I think some countries are facing that problem where there's cherry picking of the services that the private hospitals, for example, might offer. So they're more profitable services. We found in a number of countries they have, the private systems have longer or risk-adjusted lengths of stay and the like. So, and there is an administrative burden as well, which is a drag on efficiency. So you're starting to add in these inefficiencies the more you go down that road, potentially, unless you can control or regulate.
I guess the analog of this in the United States, which did not come from policy, is concierge medicine, where some physicians take themselves completely out of the delivery system for the bulk of us to give a higher level of care. And my sense is that it's been going on for quite a long time. I used to get calls from the press 10, 15 years ago about it, and it hasn't really become that dominant. We've just about run out of time, and I want to close by thanking a bunch of people. First, the panelists, who I thought did magnificent work for this webinar. You really made the webinar a good thing because of your work. Also like to thank my Brookings colleagues, Matt Fiedler and Lauren Adler, who worked with me over what seems to be a very long period of time. This meeting initially was supposed to be an in-person in May, and obviously we didn't go forward with that. I want to thank Brianna Nicker and many at Brookings who provided terrific support. And finally, I wanted to thank the Robert Wood Johnson Foundation for financial support that made these webinars possible.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.